Good afternoon to all attendees. My name is Shruti. I'm part of the marketing team for Elsevier India. I would like to welcome all of you for today's masterclass by Dr. Rangarajan V. Before we start today's session, I would like to lay out some of the ground rules or the hygiene rules as we call it for today's session, which we have to abide to so that we can make maximum out of this session. First thing is, all of us are going to remain on mute. So if you want to ask any question, please make sure that you're putting that question in the Q&A tab at the bottom of your screen and not writing anything in the chat section. If you write anything in the chat section, that comment or post will not be acknowledged or answered to. So please ensure that all the questions are being posted in the Q&A tab. This session is already in recording and a recorded version will be circulated to all of you. Post this session through an email so that you can relearn what you have learned today by Dr. Rangarajan. Also, there will be an interesting question and answer session towards the end of today's webinar. So please post as many questions as you want. We will try to answer as many questions as we can. But considering the fact that we have limitation of time, we might not be able to answer all of them today. So we will get back to you with the answers to your questions through an email on a later date. With this, I would like to hand over today's session to my colleague, Ram, who will be moderating today's session along with me. And Ram will be introducing you to today's session and Dr. Rangarajan. Over to you, Ram.
So good evening all. So about the speaker, the speaker is well known to all of you. So just few words about Dr. Professor V. Rangarajan. He is a prosthodontist, diplomate in oral implantology. He did fellow in TMD, orofacial fine, obstetric sleep apnea, and dental sleep medicine from Smile USA and Roseman University. Professor Rangarajan also a dental advisor for Sri Venkateswara Dental College. He is a past president of IDA Madras branch. He is a past secretary cum treasurer, permanent EC member of Indian Prosthodontic Society. He is also a council member of Asian Academy of Prosthodontics. Professor V. Rangarajan has published many international and national journals, and Professor V. Rangarajan, along with Dr. Padmanabhan, has authored a textbook of prosthodontics with Elsevier, which is in the second edition. With a few words, I will open the session for Professor V. Rangarajan to take us through the topic today. Sir.
Thank you so much, Ram Kumar, for the introduction, and indeed it's a pleasure to be going live with so many students across the country. And also good to know that many of them are following our textbook of prosthodontics. So it really is a pleasure to probably meet one-on-one thousands of students who are across the country. Really appreciate it, and thanks to Elsevier for this organization and arrangement. So without much ado, I want to dive into the topic as we do not have much time, and it is a pretty important topic for the undergraduate final year exam as well as for the theory and practicals. So we are going to talk on maxillomandibular relationships and relations and mandibular movements. That's the topic for today. As you all know, these are the various steps in the making of a complete denture. The clinical steps are given onto the left column, and the lab steps are given on the right. So we start with diagnosis and treatment planning, make diagnostic casts, then mouth preparation, primary impressions, then pour the primary casts, make custom trays, make secondary impressions, pour secondary casts, and then fabricate the record bases and occlusal rims. And that is when you are going to make jaw relation record, so that you can then proceed with articulation, teeth arrangement, trying, and the various other steps in the complete denture. So jaw relation record is an extremely important record, which is going to be transferred from the patient to the articular. That is very, very vital to the success of any complete denture. Before going into jaw relation record itself, though I'm not going to spend much time on structure of TMJ, all we need to understand here is that we are going to have the condyle, which is basically moving against the contours of the glenoid fossa. So that is the glenoid fossa, and this is the articular eminence. Basically, all the movements of the condyle are going to be along the contours of the glenoid fossa. So the shape of the glenoid fossa is very important for us to understand. And of course, all of you should know at your level, you must have read it in oral anatomy also. So it's very important at your level to understand what is the articular disc, the ligaments that are attached to the TMJ, the muscles that are attached to the TMJ, and the retrodiscal tissues and various other things in the temporomandibular joint. But for us right now today, the basic thing to understand is that mandibular condyle basically traverses the contours of the glenoid fossa for performing mandibular movements. Now, the mandibular movements themselves are very complex and they vary among individuals and also within the same individual. And what does an articulator do? Basically, the articulator tries to simulate the mandibular movements of the patient. Though when you are doing a complete denture, obviously at your undergraduate level, you are not trying to simulate mandibular movements of the patients because your articulator that you're using is a flat plane articulator or otherwise a non-adjustable articulator. But at a postgraduate level, when we take prosthodontics to the next level, we definitely try to simulate the mandibular movements of the patient, at least to some extent. So what are the factors affecting these mandibular movements? One is the condylar path. Second is the opposing tooth contact and the anterior guidance. And the third is the neuromuscular system. So these are the three things. And of course, the most important is the condylar path. So this is the path traveled by the condyle, as I told you before, during mandibular movement. So it's just not the mandible, it's the condyle that is moving along the contours of the glenoid fossa. So what all does it depend on? It depends on the inclination of the glenoid fossa, the tone of muscles responsible for mandibular movements and the nerve controls, all the muscles of mastication, the attached ligaments, shape and movement of the articular disc, also teeth when present. Of course, in completely edentulous situation, you are not going to have teeth present. So these are the factors affecting the condylar path. So when we look at the condylar path and the movements that are created by the condyle, we come across 5 movements. Let's first look at the basic movement. The basic movement is rotation and translation. So what is rotation? Rotation is basically just the action of or process of rotating on or as if on an axis or center, just like a ball or a sphere rotating. Now, translation is when you throw the ball, when the ball itself starts moving. So that can be from one point to another point. That is translation. So that is the difference between rotation and translation. So for example, here on here the condyle is rotating on its horizontal axis. When it's rotating on its horizontal axis, what type of movement is it doing? It is doing just opening and closing movement. In this picture here, in this second picture here, the condyle is rotating on its frontal axis. So when it is rotating on its frontal axis, makes this kind of movement. And the third picture in bottom, the condyle is rotating on the sagittal axis. So it's making a movement according to this direction. So this is what you need to understand. Both the second and third pictures, the condyle is basically making movements or lateral excursions. So in all these movements, you should understand there is a combination of rotation and translation that is happening. It's not just the condyle is staying in one place and rotating. It is also moving along the contours of the glenoid fossa. So that was the basic movements, which is basically rotation and translation. The excursive movements, the definition of which is any movement occurring when the mandible moves away from intercuspation or maximum intercuspation. All of you know that when all the teeth are in contact, you have maximum intercuspation. So when the mandible or condyle basically moves away from that, maybe in protrusive or right or left lateral or even retrusive, those are called as excursive movements. And these are all, as I said before, combination of rotation and translation. So what are the various excursive movements? We have opening movement, protrusion and retrusion, and lateral excursion. So what is opening? Initially, when the jaw is just opening about 10 millimeters, there is just only rotation in the condyle. There is no translation. After that initial rotation, as the jaw opens further, the condyle moves downward and forward. So that is, and then goes on to maximal opening. That is the basic science behind rotation. Initially for about 12 to 15 millimeters, as you're just opening a little bit, there is only rotation. As you open further, the condyle just dives downward and forward. When we look at protrusion, again, this is the translatory movement as the mandible moves anterior to centric. Meaning centric, we all know, is like almost the border movement or the most retruded position. From there, the condyle just moves forward and goes and joins edge to edge the teeth. It can also move further forward and it can go beyond the upper anterior teeth also. So that is protrusion. Functionally, we will take only up till edge to edge. And when the condyle comes forward, and especially in natural teeth, what happens when the condyles are coming forward and teeth are edge to edge? The posterior teeth are separated. So that separation is called as Christensen's phenomena. That is important for you to know and understand. So why are we doing all these things? You will be able to understand that by the protrusive and the lateral movement, basically we are trying to measure two angles of the patient and transfer it to the articulator. The first is with the protrusive movement, we are trying to get the protrusive condylar inclination, or what is called as the horizontal condylar guidance angle. Now here we are looking at the condyle from the side. I told you when we are looking at from the side, the condyle, what is it doing? It is basically starting from centric, which is like almost at the back, and then it is moving downward and forward. It's not moving straight, it's moving in a curve. But when we connect these 2 points, the starting and the end, which is probably the edge to edge point, we will get one line, which is this line. So this line and then this frontal axis, they make an angle. That is this angle. This angle is called as the horizontal condylar guidance angle. And basically that is seen from the side, and that is recorded with a protrusive record. Just like a centric record, you have a protrusive record. And we will be adjusting this angle, this protrusive or horizontal condylar guidance angle. We will be adjusting with a protrusive record, so we know how the mandible moves in protrusion. The next movement that and of course with protrusion will come retrusion, which is just the opposite of protrusion. It occurs when the mandible moves posteriorly from the intercuspal position. All of you from your intercuspal position try to move your jaw further back. It really won't move further back much. It will move a little bit, maybe a millimeter or so. So as I said, that distance is quite small, as it is restricted by the ligamentous structures and the retrodiscal tissues, and it's not of much of clinical significance, except that I'll tell you when I talk to you about centric relation, especially in natural teeth. So we saw protrusion, and with protrusion we saw the horizontal condylar guidance angle. Now with lateral excursion, what happens? So lateral excursion is produced when the mandible moves from side to side, either to the right or to the left. Now the side to which the mandible moves is called as the working side. Now I'm moving my jaw to the right. The right side is called as the working side. The right side condyle is called as the working side condyle. And the left side, which actually you will be able to feel only the left side moving when the jaw is moving to the right, that is called as the balancing side. And that condyle is called as balancing side condyle. So what movement takes place on the working side and the balancing side? You can all try. When you move your jaw to the right side is really not moving that much. So what's happening in the right side? There is just a shift of the condyle. It just shifts slightly in the same plane, maybe little downward forward, but only a side shift is there. And that shift is called as Bennett shift. Now, but what happens in the working side condyle? The working side condyle basically moves downward, forward, and medially. So it not only moves downward, forward like protrusion, but it also moves medially. That is the movement that is taking place on the balancing side. So for example, you can see here, this is where I'm looking at the condyle from front now. For the protrusion, I was looking at the condyle from the side. Now I'm looking at the condyle from the front. So my centric relation is somewhere here. The condyle moves downward forward and then moves medially. So this is the beginning and this is the end. This is the end. I join that line and then I join, and then along with the sagittal plane, this makes an angle. And this angle is called as lateral condylar guidance angle or the Bennett angle. So we need to understand two things. The horizontal condylar guidance angle is provided by the protrusive record. The lateral condylar guidance angle is provided by the lateral record or the Hanov formula, which we will see later. So these two are important. That's why we, apart from centric, we also try to record the eccentric jaw relation or eccentric relations or records, as we will see in the section of on maxillomandibular jaw relations. This just to show you a quick, a small video. Concentrate on the condyle here. Okay, just concentrate on the condyle. First is the opening axis. You will see that in the opening axis, there is hardly any movement in the first, few degrees of jaw separation, and then the condyle moves. And then you will also see protrusion. You will see lateral and retrateral. What is happening to this side condyle? So this is the opening. So move downward and forward. Next is the protrusion. Again, downward and forward along the contours of glenoid fossa. Now this is the left lateral. The left condyle is as such, and right lateral. Only when we are doing right lateral, the left side condyle, you can see it is moving downward, forward, and medially. So next, coming to border movements, which are the extreme movements. How much, to what extent your jaw can move forward, right, left, back. Those are all the border movements. So mandibular movement at limits dictated by anatomic structures as viewed in a given plane. So you can view the border movement from the side, you can view it from the front, you can view it from the top. So 3 planes you can view the border movement. This is very useful for jaw relation because some of these border movements are repeatable, like your centric jaw relation. So who described the border movements? Posselt described the extremes of mandibular movement as limited by anatomic structures and teeth. For example, I move the jaw to the right, and I can't go beyond that. That is my extreme. That is the border. I move the jaw in protrusion maximum. That is border. I can't go beyond that. I take my jaw back. That is border. I can't go beyond that. So these are all the border movements, and the whole thing, when it is joined together, is called as the envelope of. It's called as envelope of motion. So this is the border movement that is happening in basically in the sagittal plane. So we are looking at it from the side. I'll just quickly show you a video. Basically, this is CR. This is for natural teeth. Okay. So there could be a centric relation and there could be a maximum intercuspal position. Meaning, many of you, when you're biting with maximum intercuspal position, would still be able to move your jaw slightly back, more back. That is called as centric relation. But your maximum intercuspal position will be slight is when all the teeth are coming into contact. So there may be some discrepancy there in natural teeth, but in complete denture, MIP is at CR. So that very well needs to be understood, which we are going to talk about later also. So this is in the sagittal plane. As you're looking at it from the side, so this is the kind of graph that the mouth wide open, then goes back, okay, to centric relation position and centric occlusion, and then maximum protrusive. So these are the border movements that are taking place when the patient is moving the jaw, opening and moving the jaw and protruding the jaw. Obviously, you can't see right and left movements over here when this sort of a movement is taking place from the side. So we are not bothered about the right and left lateral movement. Now, this is the movement that is going to be seen in the frontal plane. So this is the kind of graph or diagram that you will get: maximum intercuspal, right, left lateral, maximum right lateral, and protrusive. So just to show you the video on that. So this, we are viewing the mandibular movement from front. So as we are moving it from maximum opening, then go to the right lateral, then go back to the centric or MIP position, and then, or centric occlusion, and then go to the left lateral position. So that is when you're viewing it from the frontal plane. Now what happens when you view it from top, that is the horizontal plane? You are going to get, this is typical of the Gothic arch tracing that we are going to talk about in the end. This is the kind of movement that takes place with a Gothic arch tracer. You are basically seeing the movement in the horizontal plane or right from the top. So what is happening here? So basically centric relation, again right lateral, left lateral, and protrusive. So you are going to get something like an arrowhead tracing or even a diamond shaped tracing. That is what you are going to get. So those were the border movements. We saw basic movements, we saw excursive movements, we saw border movements. Now we are coming to functional movements. So this is what happens when you're speaking, when you're swallowing, when you're chewing, when you're yawning, and various. These are all on a day-to-day basis. You're doing all these movements. You can see all these movements fall under the various border movements that you are seeing in different planes. So these are all called as teardrops. One border movement, as you open, close, chew, speak, swallow, goes from centric. So this is all of it starts with centric and ends with centric. So you start, open, close, and these are all the functional movements, and all these will be taking within the confines of these border movements. That's important for you to understand. And then of course we have the parafunctional movements. Now these are not normal. These are sustained movements of the mandible that occur other than the normal, manifested by long periods of increased muscle activity, and they are almost impossible for the patient to control. Obviously, all of you know the two most common types of parafunctional activity are bruxism and clenching, even nail biting, pencil biting, pipe, biting on the pipe. All these things also fall under parafunctional movements or habits. So now we saw the condylar path and the various movements. The next factor that affects the mandibular movements is the opposing tooth contact and anterior guide. It's very important at an under level, apart from the undergraduate level. What do we all do? We all do what is called as balanced occlusion in the postgraduate level, so that there is a smooth contact of the opposing teeth, and that prevents any mandibular deflection and displacement of the denture. So in your case, what you're doing, you are basically adjusting there is going to be a discrepancy whenever you give or deliver your complete denture. But how are you rectifying it? By doing occlusal grinding and occlusal correction, the deflective contacts, because the movement of the articulator is not the same as the movement of the patient in the dentures that you are doing at an undergraduate level. So you will try to correct it to a certain, and you are not giving balanced occlusion. So you will try to correct it to a certain level by doing occlusal equilibration. Also, thankfully for most of us, the patients are chewing just in an opening and closing method and don't really move and chew. So when you want to make the chewing more comfortable, then you need to give what is called as balanced occlusion. And anterior guidance. What is anterior guidance? The way the lower anterior tooth moves along the inclines of the upper anterior teeth, that is another guiding factor. And all of you know, in factors affecting balanced occlusion, incisal guide angle is one of the important factors. And we also know that incisal guidance or anterior guidance in balanced occlusion, we want to keep it as low as possible, or to 0 degrees, as much as aesthetics and phonetics will permit. So this anterior guidance can be altered by us, by the dentist, to achieve a balanced and smooth occlusion. So the most important thing to understand here is we want to place our teeth and the occlusion and the inclines in such a way that the interferences are eliminated when the jaw is moving in excursive movements. That is why we say that the opposing tooth and anterior guidance is also important for mandibular movement, especially in complete dentures. And for that is totally in our hands. We can achieve that. The third most important thing which affects mandibular movement is the neuromuscular system. And all of you should know about the muscles of mastication, because they are basically associated with all the movements, the opening, closing, right, lateral, left, lateral, protrusive, and the fixation of or stabilization of mandible, such that there is a smooth and coordinated movement. So if you are going to have some kind of a spasm, probably in lateral pterygoid, you can't move the jaw, probably you may not be able to protrude the jaw. If you have a spasm of medial pterygoid, you can't move there will be very limited movement to one side or to the other side. If you have a problem with the masseter and temporalis, you may not be able to open the mouth. So again, mandibular movements are affected by muscles of mastication, and they are unfortunately controlled by the central nervous system. That is a totally different ball game. If there is a neuromuscular problem, that is for the joint experts and orofacial pain experts to deal with. So you just need to understand at your level that the neuromuscular system also plays a role in smooth functioning of the mandibular movement. So three things for you to understand in mandibular movements. One is the condylar path. Second is the tooth and the anterior guidance. And third is the neuromuscular system. And all of you should know what are the functions of each of these muscles of mastication. And finally, the significance of mandibular movements. They are very useful for recording jaw relation, no question about it. Also for selection and adjustment of the articulator, developing tooth form, as I said, tooth form for the dental restoration, understanding the basic principles of occlusion, diagnosis and treatment of TMJ disturbances, and preserving periodontal health. Because preserving periodontal health may not be important in a complete denture patient, but if you are going to give deflective occlusal contacts in a fixed prosthesis for a natural tooth patient, you are going to get into trouble. You could damage the periodontal attachments. So that is how significant this mandibular movement is. And these are the various factors which affect the significance of mandibular movements. Now coming to the maxillomandibular relationship itself, I'm sure all of you understand it is any spatial relationship, any relationship between mandible to mandible, maxilla. It can be here, it can be here, it can be here, it can be here, any relationship. There's infinite relationships are there. And what is a maxillomandibular relationship record? Any registration of a positional relationship, for example, centric, protrusive, lateral. So basically you're asking the patient to bite in one position and taking a record. That is a positional relationship of the mandible relative to maxilla. And these records may be made at any vertical, horizontal, or lateral relation. And a synonym for maxillomandibular relationship record is a jaw relation record and jaw relations. So these are the three things which you need to understand. First is orientation relation, second is vertical relation, and third is the horizontal relation. Now, what is the orientation relation? Obviously, you are not doing or trying to get the orientation relation at an undergraduate level when you are making your complete dentures. But when you want the condyle or movement to be simulated as according to how it is in the patient and transfer that to the articulator, which is capable of receiving that kind of a record, then you are supposed to also get the orientation relation. What is basically, it establishes the angle or tilt of the maxilla. Angle or tilt, the tilt of the maxilla. When you look at it from side, the maxilla can be like this, it can be like this, it can be like this. When you look at it from front, the maxilla actually could be tilted like this or tilted like this. So basically, it established the angle or tilt of the maxilla in 3 reference planes, and the mandible moves against a fixed maxilla. All of you know that. And to accurately reproduce mandibular movements, it is necessary to establish and record the tilt of the mandible, of the maxilla, because at the end of the day, the mandible is moving against the maxilla. So orientation relation, this is what I said. This basically records the tilt of the maxilla. To record the angulation of the maxilla, so you want to record the angle of the maxilla. So what the tilt basically? What you need to have? You need to have two. You need to get two, like a plane. If you want a plane, you need 2 points at the back and probably 1 point in the front. So to record the angulation of the maxilla, a plane should be formed with at least 2 posterior references and 1 anterior. So 1, 2. So these are the 2 posterior and 1 anterior reference. Then it forms a plane. Then you will be able to do it. So as the mouth opens and closes in centric relation, the condyle rotates, I told you, and the axis of rotation passes through the condylar center. So if the center of condylar rotation can be determined, it will correspond to the two posterior reference points. Now you can say that now that is in the mandible, but we want to obtain the tilt of the maxilla. Why are we, getting two reference points in the mandible? So it's just that, it is easy to get the condylar center. Now what is above the condylar center? It is a fixed structure, that is the glenoid fossa. Now that is a reference, solid reference to the maxilla. So if we are able to get the condylar center, it is like almost we have got the two posterior references for the maxilla. So that's the way we try. That's the analogy behind this as to why we are getting the reference in the mandible when we want to have a plane for or determine a plane for the maxilla, because the glenoid fossa is almost just above the center. It is almost just separated by your articular disc. So we can almost say that that is equal to the glenoid fossa. So this is a repeatable, and as I said before, the centric relation position is a repeatable border position, and anybody even without teeth can go to that position, and you can get that posterior reference very easily and consistently. And of course we will need these two of the two posterior. As I said, we need one more anterior, which could be the infraorbital notch or the nace ion, and that will complete your plane. So this is what we are trying to say. This is like an articulator, and this is the articulator. One condyle, the other condyle, and then the anterior. This is just superimposing the face on an articulator. So you get the plane. Once you get the plane, then you get the tilt of the maxilla. The exact tilt that the patient has, you will be able to transfer to the articulator. So obviously all of you know that the instrument that is used to record this is called as the face bow. Quickly let us go to the face bow. You know the definition and you need to go through the definition. I don't want to waste time on it. It is a caliper like clitoris. You now know what it is used for. It is used to record the spatial relationship of the maxillary arch to some anatomic reference points and then transfer it to an articulator. So what are the types of face bows? You have arbitrary face bow and you have kinematic face bow. The arbitrary face bow determines the approximate center of rotation. So what we are determining will be within about 5 millimeter of the center of rotation of the condyle, while the kinematic face bow establishes the center accurately. So it's okay, even if we use as arbitrary face bow is okay, because the discrepancy is not much and you will be able to, probably you will only end up with a minor occlusal correction when you are delivering your dentures. Arbitrary face bows can be either earpiece or fascia type. I'm sure all of you understand. One goes into the ear, other goes on the proposed condylar center. So what is this earpiece face bow? It goes basically into the external auditory meatus and is considered as a reference point to determine the center of condylar rotation. The condyles are located now obviously this external auditory meatus is obviously not the condylar center, but you want the condylar center. So where is the condylar center located? Is it in front of the external auditory meatus? Yes, it is in front of the external auditory meatus at a few millimeters in front. And how you can achieve this discrepancy that you have made with your face bow, the earpiece. In the articulator also, you will attach this slightly behind the condylar center, which we will see. So this type of face bow is easy to manipulate because nothing, just put it in the ear, make sure the distance is correct, put the bite rim and go. It's very easy. So this is your earpiece type of face bow. See here, basically the condylar rod has gone into the ear instead of onto the condyle, and the condylar center is basically somewhere anterior on your preauricular region. And this is, and that, see here, now you understand what I'm trying to say. Now when I'm taking it to the articulator, see where the earpiece is going. It is going behind the center. This is the center, and the earpiece is actually attaching not in the center but behind the center, because the external auditory meatus was used. If I had used the center as the point, I would have, this earpiece would have gone and attached itself to the center. That is how we get the center when we transfer it to the articulator. So this is the earpiece face bow. Now the fascia face bow, what are we trying to do? The center is arbitrarily marked. Here also it is not pakka, but we are trying to get the center here. We are not using the external auditory meatus. So marked as 13 millimeter anterior to the middle of the tragus of the ear on a line drawn from the outer canthus of the line of the eye to the middle of tragus of the ear, or the canthotragal. From the canthotragal line, you just cut off 13 millimeters and we place our down. That is it. This is your canthotragal line. And on that, from the superior part of the tragus, mark about 13 millimeters and keep a micropore tape there. That is supposed to be your approximate center of condylar rotation. And see, we are fixing our face bow condylar rods in that position, which is the center. So when we are taking it back to the articulator, the face bow will go into the center. It won't go and attach behind, as it happened for our earpiece type of face bow. So here it goes and directly attaches in the center. So that's the difference. Both are arbitrary. Both are not accurate. Both are just arbitrary. So that is fascia and earpiece type of face bow. Now with the kinematic face bow, what happens is we are trying to get the true center of rotation of the condyle. So basically, it is like something like this. Now, when I am moving and you can see this pen and this ball. If I'm going to put the pen directly in the center of the ball, as the ball rotates, this pen only rotates. It does not move. Now, any other point other than the center, if I'm going to keep the pen, and can you see, as I move the ball, the pen also moves or it translates. So only in the center, only that one point in the center will only rotate and it will not move. It will not translate. So that is the principle or philosophy with which this kinematic face bow works. And usually we don't use it for complete denture patient. We use it for full mouth reconstructions and with fully adjustable articulators for full mouth reconstruction. This is just for your understanding. We don't need to go into a very big level. As I said, only the center point rotates in any sphere. The rest, even half a micrometer away from that center, will only translate it. So in what principle are we doing? We are keeping 2 points which are going right into the condyle. And we are asking the patient to get open about 10 millimeter. In 10 millimeter, what movement is taking place? Only rotation of the condyle. And if you are in the center, this stylus will not move. Any other point, if you keep on the condyle, the stylus will move. That is the principle. So by trial and error, we keep the stylus at various points attached to the condyle here and ask the patient to keep opening and moving and get the point where the stylus only rotates and does not translate. And that is our true center of condylar rotation, which we mark, and then everything else is the same, the bite fork and other things. So quickly about the parts of the face bow, you have the U-shaped frame, you have the condylar rods, you have these locking nuts, you have what is called as a bite fork with which you put the bite rim, and then you have the pointer, the anterior pointer, third point of reference. So that is basically how it is to look at, and this is how it is. You can see the third point of reference, and then the 2 posterior points will give us the plane, so that we can get the tilt of the maxilla in relation to the cranium and transfer that to the articulator. So what are the indications of face bow? When balanced occlusion is necessary, definitely face bow is important, and when the vertical dimension is subject to a change. Now, for example, I have made for a natural tooth also, or for a complete denture, I have made an orientation jaw relation with the face bow. Now, after doing everything, I have attached the maxillary cast, I have attached the mandibular cast. Now, suddenly I find that, maybe at the time of try-in, I find that I need to increase the vertical dimension by a couple of millimeters. With appropriate, articulators, I can just, all of you know the incisal pin, isn't it? If I just raise the incisal pin by 2 millimeters, I can get that correct vertical. The movement of that will be the same as the movement of the patient. So I can just adjust it in the articulator itself rather than go back and try to, get the record again from the patient. So that is the meaning of when vertical dimension is subject to a change. So, and then once we get the record, face bow record, we transfer it to the articulator And you can see how nicely the tilt of the maxilla as coordinated with the patient is obtained. So first procedure in jaw relation record is to first obtain vertical relation and first articulate the maxillary cast. So once we have articulated the maxillary cast, then with our vertical and horizontal jaw relation, we will attach the mandibular cast to the maxillary cast. And I will skip this as we don't have time, and this is just a video of a Facebook transfer. I'm sure this is there in our Elsevier site, and many of you will be able to go and access it, those who have the book. So go and access it, and we have it's self-explanatory there. So we have finished the orientation jaw relation. Now we'll go to the vertical relations. So what is vertical relation or vertical dimension? This is the length of the face as determined by the amount of separation of the jaws under specified conditions. It is important to record the horizontal jaw relation at the appropriate vertical dimension, which is normal for the individual. That's why we record the vertical jaw relation first and then go for the horizontal jaw relation. And the vertical dimension is maintained by the occlusion of teeth. Of course, in complete denture patients, there is no occlusion of teeth, or by the mandibular musculature. So what are the types, which is very, very important for us to understand? Vertical dimension at rest, vertical dimension in occlusion, and vertical dimension in other position, which we are not really bothered about. Obviously, you can open the mouth and sit like that and get a vertical dimension. We are not worried about it. We are worried about vertical dimension at rest and vertical dimension in occlusion. So the vertical dimension at rest and physiologic rest position is almost the same. So it is basically the postural position of the mandible when an individual is resting comfortably in an upright position and the associated muscles are in a state of minimal contractual activity. So it's obviously, even when you are just keeping your mouth, close together without the teeth touching, muscles are functioning to a certain level to suspend the jaw in that position. It's not like there's no zero activity of the muscles. The elevator muscles and the depressor muscles are working, together to hold it in that position. So that is your physiologic rest position, and this is a position that can be repeated. So it is imperative that teeth should not contact in rest position. All of you know that, and a space exists, and that is called as freeway space. And this is a comfortable position, allows the supporting hard and soft tissues to rest. Contact of teeth in this position will be similar to so if suppose you're just sitting like that and within a relaxed position and teeth are touching, that is like premature contact, and that constant contact of the teeth will lead to soreness, especially in your complete denture patients, and bone resorption. So vertical distance between the teeth at rest position, as you know, is termed as freeway space. In the dentulous patients, this freeway space this freeway space varies from 1 to 10 millimeters with an average of about 2 to 4 mm. The older the complete denture patient, you should give more interocclusal rest space. For a 60-year-old, I will give about 5 to 6 millimeter of rest space. For a 40-year-old, if I do complete denture, I'll maybe give a 2 millimeter rest space. So does not depend on the presence of teeth and is repeatable and recordable. That's why this is important, because vertical dimension of occlusion, as you all know, is vertical dimension of rest minus 2 to 4 mm. So what are the factors influencing rest position? Posture. As I said, the patient has to be sitting comfortably in an upright position, because the vertical dimension will change if the patient is sitting like this or sitting like this or putting their head back. So it will change. So you have to make the patient sit upright and in a comfortable position. Very important that the patient is relaxed and not under great deal of stress. Then it's difficult to get the rest position. And patient should not be having any neuromuscular disturbance. Otherwise, you are going to get a lot of wrong recordings. And you should take it quickly. You should take multiple recordings quickly, because this keeps changing within few seconds. And just one method is not enough. You should use several methods and take an average of several methods. Those are the factors influencing the rest position. So what are the methods of recording? I'm sure you understand this: facial measurements and anatomic landmark. So what do? We mark a point at the chin and the nose, and with a caliper or divider, measure it. So how do we do that? We can get that way. We can also use what is called as a Willis gauge. Okay, this is a Willis gauge which is used for recording the the vertical relations. And measurement of anatomical landmarks. One is the Willis guide. What does the Willis guide say? That the distance from the pupil of the eye to the rima oris should be equal to the distance from the anterior nasal spine to the lower border of mandible. Or in other words, this distance should be equal to this distance when the jaw is in rest position. So that is one method of verifying. So what are the various methods how you can use to get the physiologic rest position? One is the swallowing. Ask the patient to swallow and close. All of you can also try it. Swallow and close, automatically you will go to the rest position. Second is tactile sense. Keep the jaw wide open for about 1 to 2, let's say 30 seconds also is enough. And then ask the patient to close. Immediately the patient will go into rest position. Immediately record that measurement. Phonetics. Ask the patient to say the syllable with the teeth, the lips meet. M, Emma, Ram, anything. So Mississippi. So anything like that you can ask the patient to say. And as you say M, ask the patient to close and relax. So measure. So, and also by the facial expression, the following indicates the rest position. Lips are even antero-posteriorly. You will generally feel that the skin around the eyes and chin are relaxed, and the patient, is having an unobstructed breathing. So, but you will generally be using the swallowing threshold, the tactile sense, and phonetics for determining this. So we have now determined the vertical dimension of rest. Maybe it is 60 millimeters. Now we will record the vertical dimension of occlusion. So this can be divided into physiologic methods and mechanical methods. So what are the physiologic methods? I am only going to go through Niswanger's method because that is what you are doing. I would like you to read up on swallowing threshold, phonetics, neuromuscular, and aesthetics. I have just rushed through them because of lack of time. So Niswanger's method, what do we do? All of you know, we have contoured the maxillary and mandibular occlusal rims, the labial fullness, everything. We put it in the patient's mouth. We determine the vertical dimension of rest, 60 millimeters. Now we keep reducing the wax so that when the patient bites, there's even contact with the maxillary and mandibular rims, and the distance measured now will be about 58 or 57. So 2 to 4 millimeters less than vertical dimension of rest. That is how you determine vertical dimension of occlusion with your Niswanger's method. This is also given in the video file. So swallowing threshold quickly, it is dependent on teeth coming into light contact at the beginning of a cycle. So what we generally do is make wax cones in the mandibular rim, ask the patient to swallow, and we see if the wax cones are blunting. And when the upper rim just touches it, that means that is your vertical dimension, correct vertical dimension of occlusion. Closer speaking space is another important question for in the exams also, and this is otherwise called as the Silverman space. So this depends on how the patient, when the patient is pronouncing the word S, you can see the maxillary and mandibular anterior teeth coming almost into contact but not touching. That will give you the reference for your vertical dimension. If they touch, that means your vertical dimension is too low. If there is too much of a gap, that means your vertical dimension is too high. So that is Silverman space, and Silverman coined this term. That's why, though Pound was the person who basically proposed this, but Silverman coined this term. And you can also use not only the S sound, ch and j. You can see the maxillary and mandibular anterior teeth coming together. Then we have neuromuscular perception, which is using the central bearing device. You can have a lower occlusal rim with a plate and the screw here, and the upper occlusal rim with a plate. So basically, what are we trying to do? We are trying to use neuromuscular perception. First, what do? We increase the screw. Screw can be moved up and down. Okay, so we increase the screw. The central bearing screw is first placed such that it is obviously too long, and you keep reducing it, keep asking the patient to close. And finally, the screw we know it is vertical dimension of occlusion when the patient says that I am comfortable now. I don't feel like I am either under closing or over closing. That is neuromuscular perception. Then we have the PowerPoint by Booz, who in 1940 demonstrated that the maximum biting force is registered at vertical dimension at rest. Remember that here. Here what we did was, apart from that screw that was there, we also attach a pressure meter or a pressure indicating gauge, and we keep adjusting the screw and checking the pressure. So at vertical dimension rest, the maxilla, let's say 40 pounds, and the rest is all 38. So that is vertical dimension rest, and minus 2 millimeters will give us the vertical dimension of occlusion. The device is called as bimeter, and the maximum biting point is called as power point. So this boost bimeter is another thing that you need to understand for your exam point of view. And aesthetics also, you just looking at a patient, you can very clearly see here, whole lips are full. This is like an increased vertical dimension. Everything is stretched. The nose to chin distance is more. So you just looking at the patient, you will be able to say that is an increase in vertical dimension. And just looking at this patient, you will say that there is a decrease in vertical dimension. So that is just aesthetics. You know, here you can see that there is too much closure of the upper and lower lip. You can see the folds that are forming, all the wrinkles and the folds. So all this will give you an idea of the decreased vertical dimension. Mechanical methods are ridge relationships. For example, the incisive papilla. This is to verify, after you have recorded, to verify when you're doing the teeth setting, from the incisors to the incisive papilla, it should be around 4 millimeters. That means you can say, okay, we are almost there. Ridge parallelism also gives you an idea about the, and then of course, all these pre-extraction records like profile photographs, you can take a photograph when the teeth are present and compare it to make some, cardboard marking when that is there, and cut the cardboard and check it with the patient after the teeth are removed. So profile silhouettes can be checked. Radiographs are not very accurate, but that is also one of the methods. And of course, articulated casts. Casts are mounted before extraction, following extraction, and then points are marked in the cast to check the vertical dimension before and after. And of course, facial measurements. You can place tattoo marks on the patient when teeth were there and get their vertical dimension occlusion, and compare the tattoo marks after the teeth are all extracted. Measurement of former dentures. Sometimes patients will come to you with old dentures for replacement and give a new denture. So, but you should take that with a pinch of salt. They are only a guide. They should not form the basis, because over a period of time, vertical dimension with the old dentures would have decreased. So these are all the various effects of a increase in vertical dimension. You understand these are all the various problems with an increased vertical dimension. There is discomfort, trauma, TMJ problem, bone resorption, so many things. And most important, patient will not be able to chew and swallow. So you're doing a great disservice to the patient. Clattering of teeth. Every time patient is chewing or speaking, teeth will come into contact. Of course, similarly, you also have effects of decrease in vertical dimension. Cheek biting, patient will say he's not able to chew, and facial distortion. There will be angular cheilitis, is constant dripping of saliva. So all this is effects of decrease in vertical dimension. So there is no single method to determine the vertical dimension. It has to be evaluated using various methods as discussed, and all determination of vertical dimension must be considered tentative until the teeth are arranged. Again, during try-in, vertical relation again should be assessed. So coming to the horizontal relation, which is very important, as you all know, centric relation, again and again, there will be questions on centric relation. So I am giving you step by step to understand. Centric relation is obviously a maxillomandibular relation, independent of tooth contact. That is the first one. This is GPT 9, in which the condyles are, this is the anatomic form. This is the anatomic basis. So condyles articulate in the anterior-superior position against the posterior slope of the anterior articular eminence. You have to understand that. That is only an anatomical definition. In this position, what happens? The mandible is restricted to a purely rotatory movement. That is important to understand. And it is an unstrained position, and its physiologic maxillomandibular relationship. Here, from this position, the patient can make opening, closing, lateral and protrusive movements from this position. So this is the starting point for all the other positions. Well, and it is clinically useful. Why? Because it is a repeatable reference position. So all of you, you're all having natural teeth. So when you bite, that is your maximum intercuspal position, or otherwise what is called as MIP. Now, some of you from MIP may be able to move the jaw a little bit back. And from there, you can still open and close, move the jaw to the right and left, and move the jaw forward and left. That is your centric relation. So your centric relation is not coinciding with MIP in natural tooth with the maximum intercrustal position. So what is, this is maximum intercrustal position, which all of you know. So now what is centric occlusion? Now in a complete denture patient, MIP, CO and CR, everything is the same, is at CR. But what happens in natural tooth? Now I told you, some of you try to move your jaw slightly back and close your teeth. Now teeth are contacting in that position, but that is not MIP. Now that occlusion is called a centric occlusion, or the occlusion of teeth at centric relation is called as centric occlusion. Now in complete denture patients, we make sure that the MIP is given at centric relation, or the CO is at is given at centric relation. So there cannot be any discrepancy between maximum intercrustal position and centric occlusion. Whereas in natural tooth, there can be discrepancy between centric occlusion and MIP. So the centric relation is obviously a bone-to-bone relation, while the MIP is a and a CR are a tooth-to-tooth. So the occlusion is always tooth-to-tooth. This is what is most important, which is the significance of centric relation. So centric relation and MIP. In natural dentition, as I said, MIP may not coincide with centric relation. But what happens? This does not create any damage, because the proprioceptive receptors are present in the periodontal ligament, which will go away once the teeth are removed. So they direct the mandible away from any deflective contacts that are present in CR into MIP. Of course, it will create other problems like wear of the tooth, attrition, and various other problems. But you are not going to get major problems because of that. But in a complete denture patient, if you are not going to give MIP in CR, what happens? So there is going to be deflective contact. This deflective contact will cause movement of the denture base, displacement of the supporting tissues, and direct the mandible away from the path. Hence, MIP must coincide with CR. Second thing is, in what position did we do the face bow transfer? We did the face bow transfer, we did the center of condyle, all of that was recorded in CR only. We were asking the patient to open and close when we are doing, or even when you're doing the kinematic face bow. The maxillary cast is oriented in that position. So you should get the posterior border position. Hence, the mandibular cast will also be correctly oriented to the opening axis of the articulator only if it is mounted in CR, because you already did the maxillary cast in the same position. Vertical relation, I told you before also, with different, in this much vertical opening, there will be a CR. In this much vertical opening, there will be a CR. So CR differs with every vertical relation. So hence CR must be recorded as the established vertical dimension, which is normal for the individual. That's why we record the vertical dimension of occlusion first and then go for the horizontal relation. The next thing is CR is reproducible. Even without teeth, I can ask the patient to go back to CR or the most posterior position whenever. It's very easy to keep going back to that position. It is a comfortable patient. The mandible returns to its position during all its functional movements, and hence is convenient and comfortable. Easy excursion, meaning from here I can easily take the jaw. From CR, I can take the forward, right, left, back. So, and it is conducive to health. So because of these 7 factors, we are giving centric relation is important, and we are giving MIP in CR for a complete denture patient. So CR and MIP and CO will coincide in a complete denture patient. So for recording the CR, what you should do? You should retrude the mandible. So obviously you need to take the jaw backward. So there are various methods, passive methods, active methods. I would, let me not go into major details about this. Passive methods are when you ask the patient to do it and you are not guiding it in any way. That is passive methods. Any of these instructions that you give to the patient is a passive method. Active methods, obviously we are holding the chin of the patient and we place the thumb and the forefinger like how it is said here. And we don't go and push it back. We just make the patient open and close. And as he's closing, we give a slight firm, but firm posterior pressure, slight, so that the jaw doesn't come forward, that's all. We are not going to take it and push it. We are trying to, that is an active method because you are doing it for the patient. The other is, of course, the Dawson's bimanual palpation, which is another active method, where, as you can see, you are going to keep your fingers underneath the inferior border of the mandible. The thumbs are going to come in the chin area, or the anterior portion. And with your thumbs, you are giving a downward force. With your fingers, you are giving an upward force, which is going to eventually get the jaw back. That is Dawson's bimanual palpation. Sometimes you could also palpate the temporal masseter muscles, because they are your depressor muscles. You can do that to take the jaw back. So these are the various difficulties that you could encounter in in getting the recording or retruding the mandible. The recording CR itself, obviously we have to record the correct horizontal relationship of the maxilla to the mandible. We need to exert equalized pressure to remain undistorted till mounting is there. We have static methods, functional methods, and graphic methods. Static methods is just, ask the patient to bite and close, that's all. These methods are employed without, there's no movement here, are employed without the use of functional or excursive mandibular movements. They have been referred to as a centric, tentative centric. The wax occlusal rims that you are all using to record this is a static method. So whatever method you are using in the clinic is an wax occlusal rim, and that is a static method. Intraocclusal check records. Now, for example, I've come to the wax trial stage. Now I find that, there is some discrepancy. So I want to take the record. What I'll do, I will flame up a wax and I'll ask the patient to bite that and get the maxillary and mandibular trial dentures in that position or centric relation position. That is intraocclusal check record. So that is your intraocclusal. This is your wax occlusal rim. Like all of you know, first the wax occlusal rims, the upper and lower, need to be contoured completely. The maxillary and mandibular rims need to be contoured. Then the vertical dimension is established, ensuring even contact. And the patient is also trained to retrude the mandible, as with all those methods that I told you. And the various guidelines, the midline, the canine line, all these things are marked. And the patient is asked to close in centric. So once you have trained the patient, all that you need to do is you already contoured the bite rim. You have made sure it is flat and evenly meeting. You train the patient to retrude. Now ask the patient to bite and close in the retruded position. And the rims can be joined or sealed by heat, by pinning. So these are not methods that we really recommend, because they can move, even if you heat, and heating is really dangerous. You could burn the patient. So this is theoretically it can be done, but not very recommended. And there are disadvantages to both these methods. Probably the most recommended method, all of you should know what is this. This is called as the nick and the notch method. You are making a nick here. A nick is something that is partial cut. A notch on top in the molar region, and the nick in the maxillary canine region. And then you make a trough here and basically ask the patient to close and inject zinc oxyreginol impression paste and take it out once it sets. That is your nick and notch method. That is probably a much better method of recording the tentative jaw relation. This is what, and this is your intraocclusal check record, as I told you. So there are also functional methods, as we know, functional or chew-in methods. Here the patient performs movements. Patient moves the jaw anterior, posterior, right, left, and then we determine the centric using those tracings or those movements. So, but first, the starting point for this also is a static centric relation record. From that, we will start the fabrication for record basis for the functional movement. The new rims are made with increased vertical dimension, so that patient performs these functional movements and grinds down the recording medium. And here very stable records bases are needed, because you're just not asking the patient to close, you're asking the patient to move. So to ensure that the bases are very, very stable. So advantages and disadvantages I would like you to go through at your leisure. and I just want to explain the method, because needles house method, what happens here, the occlusal rims are basically fabricated from compound, impression compound. 4 metal styli, 2 in the canine region and 2 in the molar region, are placed on the occlusal rims. And as I said, the vertical dimension will be slightly raised. Put it in the patient's mouth and ask them to move various movements, all the functional movements, anterior, posterior. So basically what the patient will do, as they are moving and grinding down and getting to normal vertical dimension, they will be creating diamond shaped tracings. So this will be the protrusive, that will be the centric, and this will be right lateral and left lateral. So when you want to record the centric, you just place the styli here, or that whatever is there, the maxillary rim, and inject some material and record. So Patterson's method here, what happens is, instead of the styli, you are having wax occlusal rims, but inside the wax occlusal rims, you are making a trough or a trench, and that is filled with an equal mixture of carbonundum paste and plaster, so that you can easily grind it. The upper and lower, upper is wax. So you are going to, a trench is made, and you again ask the patient to move, and as you reduce, grind down to vertical dimension of occlusion, you are going to ask the patient to go into centric and seal it. So that is how you are going to get the, the record with Patterson's method. There is also a Mayer's method, where instead of your pumice and plaster, you will be using soft wax to generate the functional record. Then finally coming to the graphic methods. Now the graphic methods are supposed to be pretty accurate, much more accurate than all these other methods that we talked about. And basically they are getting your mandibular movement in the horizontal plane. That's what we need to understand. So Gothic arch tracing, the concept was proposed by Hesse in 1897 and popularized by Gazy in 1910, also termed as arrowhead tracing or needle point tracing. And before we go into the Gothic arch tracer, first we need to get the tentative centric with your wax occlusal rim with your nick and notch method. So you get that first. Then what you do, you now attach the Gothic arch tracer. Once the tentative centric is obtained, in that position, attach your extraoral tracer. What does this comprise of? This comprises of a central bearing plate. It comprises of a stylus, which will make the marking. And then you're going to have, in the lower jaw, you're going to have a recording plate, and again a central bearing point. So that is how you are going to have, this is how it is fixed. This is on the upper jaw, your stylus, and the lower jaw, you're going to have the recording plate. Now take this out and take it to the patient's mouth. And here you're going to make sure the styli is not touching and making the patient move the jaw. Train him to move the jaw like forward, backward, right, backward, left, backward. So train the patient to move the jaw in this position. Once he is trained, then attach back, make the sphere, the styli is touching the recording plate. You can even heat the recording plate or add a thin layer of wax there and ask the patient to make these specific movements. So when the patient has made the correct movement, you will get an arrowhead tracing or a needle point tracing. So this is centric, left lateral, right lateral, protrusive. So make the patient, you can take a thin plastic film or X-ray film, make a hole and attach it here, and make a hole in that center and put the stylus there and record it. How do you record it? You inject plaster, make some notches in the upper and lower maxillary rim, inject plaster, impression plaster, take it out. You will get something like this, which is called as a centric record. Keep it aside. You can see all these notches and elevations that are there. So whenever you want, you can take it to the articulator. Upper and lower will fit exactly in that position for a centric record. And now what we are doing, we need to, now we recorded the tentative. Now de-articulated the lower cast, go back and place your permanent, the final record with the Gothic arch tracer, and re-articulate again the lower cast. That is the correct method of doing the proper centric relation record. Then what are we going? I'm not going into the videos. The videos are there in the Elsevier site. You should be able to go and comprehend it. We also have intraoral tracers, but now see here, this styli and the central bearing point itself is, and this is the recording plate as well as the central bearing device. So this combines it. You can't see the recording being made. That's the problem with an intraoral tracer. So that is the advantage, and these are the disadvantages of an intraoral tracers. And of course, these are the indications. You have to understand, you need to have broad edentulous ridges to get these tracers in mouth and make sure there's stability. There should also be adequate intraoral space. And it is indicated in patients with a habitual centric or a patient moving the jaw forward most of the times because of prolonged edentulous state. Contraindications: you cannot do Gothica tracers with severely resorbed ridges and extremely flabby ridges. When there is a very limited intraoral space, also very difficult to do. Temporomandibular joint arthropathy and abnormal jaw relations. So this was only in one plane. Pantographic tracings are in 3 planes. You are like getting a Gothic arch tracing in 3 planes. That is pantographic tracing. This is taking it to the next level. This can be transferred only to a fully adjustable articulator. So we are not only getting the recording we are not getting only this recording, we are getting this recording and this. So basically there are 3 planes. One in the horizontal plane, one in the frontal plane, one in the sagittal plane. And there are styli in 3 directions, one down, one left, one back. So they are making the markings as the patient is moving the jaw forward, right, left. And there are articulators which are there, which can take and transfer this recording to an articulator. These kind of recordings you are going to get when the patient is moving the jaw. As you saw before, you saw these frontal plane, sagittal plane, and horizontal plane. So that was the centric record. So centric is the most important record. Without centric record, nothing is possible, because you have to arrange whether you are doing eccentric movement or not, or getting the eccentric records. Centric record is very, very important. And to ensure that the maximum intercuspal position is at centric relation is the most important thing that we need to do when we are delivering our complete dentures. That is important. Now, if you want to give balanced occlusion to the patient, then you need what is called as a eccentric record, your protrusive and your lateral records. I told you before, 2 angles you need to understand. One is the horizontal condylar guidance angle, which is obtained with the protrusive record. Just understand at this level that you get the horizontal condylar guidance angle with your protrusive record, and the Bennett angle or the lateral condylar guidance angle with your lateral record. So protrusive used to record the horizontal condylar guidance angle. The methods of recording obviously similar. You don't have to do anything. What are you going to do? Instead of keeping it the centric, for recording centric, you place this, make sure the patient was biting here on the centric position, and you injected the plaster. Now you ask the patient to bite in the protrusive position, and then you inject the plaster. That's all. So once you inject the plaster and it sets, take it out, you are going to get the protrusive record. So that you could, very similar to your centric record. Now, how you need to adjust the articulator, again, this whole concept is given in the because now you are taking the protrusive record back to the patient's mouth. So this is the centric record. See how nicely the maxillary and mandibular rims are, going and engaging the centric record. But the moment you put the protrusive record, obviously they are not going to meet, because this is a protrusive record, and the relationship that is here is your centric relation. So what you need to do is unscrew these lock nuts. Unscrew these lock nuts. So if it is, you just move the maxillary rim, and in one position, the maxillary rim or the cast will go and engage perfectly the protrusive record. And when that happens, you have to note down what angle the condyle is at that position. That is your horizontal condylar guidance angle, and make a note of it. So that is your importance of your protrusive record. Now, obviously, as I said, these all will happen. It will not fit. Once you loosen the lock nuts and move it and make sure it goes and touches, the condyle will move, and as it moves, it creates an angle. That angle you record. So see here, we have now moved the protrusive, maxillary rim in such a way that it engages the protrusive record. And as it engages completely, what is the angle that is showing here? 20 degree. So that 20 degree is your horizontal condylar guidance angle. Now again, the video is there in the site and you could go and check it up. And very similar to this is your lateral record. Most of the articulators, you don't need a lateral record. You can just use the Hanau formula. What is H? H is your horizontal condylar guidance angle. You already determined that previously with your protrusive record. So 20 by 8 plus 12. So probably, you know, something like 20 by 8 will be about 2.5 or so. So around 15 or 16 will be your lateral condylar guidance angle. So, or if some articulators are there which can take to both the lateral records. So it's very similar to what we did there. Only thing is we need to make sure that the pin touches the lateral side and not the protrusive or the center. Inject the plaster again, take out the record. Or also you can use the formula L is equal to H by 8 plus 12, which is the Hanau formula to determine the lateral condylar guidance angle or the Bennett angle. So we have the downward and forward, we have the medial. So almost most of the movement we have. Now obviously transfer it to an articulator which can produce these movements, and then we can develop what is called as balanced occlusion, which is again a separate lecture itself. So I won't be going into that. So these are all the various records or maxillomandibular relationships that we need to know: the orientation relation, the vertical relation, and the horizontal relation. The gist of it is obviously vertical dimension needs to be done first, because we need to get the centric at the established vertical dimension, which is normal for the individual. That you should never ever forget in your life, because even in your clinical practice, that is very important to understand. So record the vertical dimension occlusion very easily by recording vertical dimension rest first, and by -2 to 4 millimeters, you know the Swonger's method. And then you could use the wax occlusal rims, which you normally use for your in the clinic to your centric jaw relation. The nick and notch method is important. And of course, the more accurate methods are the graphic methods, which is the Gothic arch tracer. Now this part gave you the horizontal condylar inclination. When you look at the articulator from front, you will get these markings. This gives you the lateral condyle. This is how it moves. The condylar heads are like this. So it can move like this when you look at it from front. That gives you the lateral condylar guidance inclination or the Bennett angle. So you could do it with the Bennett with the lateral record, or you could use the formula L is equal to H by 8 plus 12. So it really was wonderful. I mean, this is a huge chapter. So I have tried to complete it in about an hour and a quarter or so. And at any point of time, it's always a pleasure for me to interact with students. And if you have any doubts, even if not today or any other things, you could always email me at drviranga@gmail.com. Was a pleasure to talking to so many thousands of you out there. And I wish you all the very best, not only in your final year exam, but also in your future, so that you are going to be extremely good dental professionals. Thank you so much.
So thanks, Doctor. This is a wonderful session. I think we really enjoyed. I think the students would also definitely enjoy. There are many questions, so like I don't think like we'll be in a position to answer all the questions, but we have we will choose because of the time, we take around 3-4 questions for the important questions whatever we have received. There is a first question, like what are the difference between acron and the non-acron articulators?
Yeah, again, say I didn't touch upon it here because that comes under the articulator section. So archon is when the condyle when it is attached to the lower member of the articulator, then it is called as archon. But sometimes the condyle, like for example, even when you all see your 3-point articulator, where is the condyle attached in your 3-point articulator? It is attached to the upper member of the articulator. So that is a non-archon articulator. So archon is when the condyle is attached to the lower member, that is your archon. When it is attached to the upper member, then it's called as non-archon.
So thank you, Doctor. Thanks for answering it. There is another question. In a right lateral movement of mandible, in a Bennett movement, is condylar movement of right condyle or left condyle?
Now, when you're moving your jaw to the right, for example, I am moving my jaw to the right, okay? You can all try it also. move your jaw to the right. Which condyle do you think is moving? Obviously, only the left condyle is moving, physically moving. The right condyle is actually in that position only, and it is just slightly shifting. So your Bennett angle will be in the left condyle, okay, in the balancing condyle, not in the right condyle. In the right condyle, you will get what is called as Bennett shift. There is only a shift of the condyle. Whereas only the left condyle, if you move, just move your jaw. All of you try to move your jaw to the right and see which condyle is moving. The left condyle is nicely moving. You can feel the strain on the left condyle. That is moving downward, forward, and medially, and that is where you measure your Bennett angle. If you want to measure the Bennett angle for the right condyle, move your jaw to the left. So move your jaw to the left, then you will be able to see your right condyle. So that is the balancing condyle. Side to which the mandible moves is called as working side. This is called as balancing side. So that's how you determine.
So thank you, doctor. That really helps. What are vertical relations recorded first, and especially why before horizontal?
I think I already told you that, because centric has to be. That's why I harped on it even in the end, because the centric jaw relation or the horizontal jaw relation has to be recorded at the vertical dimension that is normal for the patient. So that's why you need to record the vertical dimension first and then go for your centric or horizontal jaw relation.
Thank you, doctor. And why should freeway space be more in elders as compared to the younger patients?
Yeah, freeway space should be more in, because in younger patients, you know, what is going to happen? They are going to chew and they are going to generate more freeway space, and there's going to be more resorption over a period of time. And when you want to generate the look and other things, you don't want that much freeway space in the lower for aesthetic, in a younger patient for aesthetic purpose. Whereas in an upper, especially, they need to have more space for chewing, you know, and whereas these people, their jaw movement, the way they open and close their mouth in elderly person is all restricted. So giving them more freeway space will also ensure that they get adequate rest for the muscles and the TMJ. So that's why we need to give a little bit more freeway space, not greatly. Here, if you're doing about 2 millimeters, there you'll give about 4 millimeters. That's all is the difference between them. But generally, as the age increases, you want to give more freeway space than when there is less age.
So one final question, doctor. I know there are many questions. I think we can send it back to you. You can reply, and you can send them as an email. The one final question, the very interesting seems like usually we encounter the resolved ridges in the routine clinical practice. What steps should we alter to achieve retention?
Good, yeah. So in resorbed ridges, as I said, right from impression making, okay, the way you make an impression, everything depends on your diagnosis and treatment, starting with diagnosis and treatment planning. If you are going to have excessively resorbed ridges, obviously, your jaw relations, your stability of your record basis, everything is going to matter, and is going to, right from your, as I said, from the case history sheet, you need to make sure that you follow a lot of things different from what you're doing normally. So with your, as I said, even with Gothic arch tracing can be done when the ridges are firm. With resorbed ridges, what is going to happen? It's going to move quite a bit. The record bases are not going to be stable. So it may be difficult to record even Gothic arch with Gothic arch tracing with resorbed ridges. You may probably need to think of even closed mouth impressions and functional impressions when you are having resorbed ridges. So these are all impressions that you are making in open mouth, static impressions. So you may need to think of functional impressions. Now, if you go and read functional impressions there, you will understand. So you make an impression, and then what you do, you record put the record bases and occlusal rims, put an impression material, ask the patient to move the jaw like a reliner, and then record. So this could be one method to record an impression for an extremely resorbed ridge. And you will need to probably get more support from your mylohyoid ridge when you're doing border molding and other things. Probably you may when your resorbed ridge is there, you may have instability of the dentures very easily. So in your occlusion, you may have to plan for a balanced occlusion, which may be necessary so that the patient's denture is much more stable. So some of the things, these are all some of the things that you may need to look at. If you're finding it difficult to get your tentative jaw relations right, you may need to again verify it probably during your wax train, and probably check it again. As I said, re-verify, try it. So all these things are important, and also selection of teeth. You may probably look at 0-degree teeth instead of giving the patient cusp teeth. You may look at non-anatomic teeth, so that the pressure is not too great on the ridges. So these are all some of the things you may need to look at. So that starts right from your case history sheet, from your diagnosis and treatment planning, and each step is planned. What type of impression you make, what type of jaw relation you record, what type of teeth you select, what type of occlusion you give. So it depends on all these things. Probably you could go in for a metal lower denture base, so that is a little bit heavy and it will give more stability. So the way you choose your permanent denture material. So all these things will matter probably when you look at resorbed ridges, and of course how much of resorption. So various things need to be taken into consideration. That's a very good question.
So thank you, Doctor. Really appreciate for answering all the questions and patiently explaining the complete aspect of theoretical aspect as well as clinical practice, the nuances in the clinical practice. Really appreciate. For the other attendees, like more information you can always refer to the book of prosthodontics. And thanks for connecting us today. And we have one more interesting session which is on 26th June. Please reserve your seat by clicking on the link. And we are looking forward to see you all on 26th. Thanks everybody, and specifically thanks Professor for your time, patient session. Thank you.
Thank you, and all the best to everybody. Thank you.